A very good morning to everyone. The topic of the first lecture of the day on voice management and pathologies is laryngeal electromyography. We would be covering the following subtopics after a brief introduction: how to do LEMG, the various applications, how to read the LEMG, and various clinical scenarios associated and when we require LEMG in our clinical practice. LEMG was first introduced by Wedel et al. In 1944, advanced by Fabog-Anderson in 1950s. It plays a very important role in the identification of a nerve problem, predict the possibility for recovery or the risk of permanent loss of nerve function. Hence, it helps to prognosticate nerve palsies. It also helps us to guide various treatment strategies. EMG cannot be done without electrodes. So first, an understanding of electrodes is very important. It helps us to sense the electrical impulses within the muscle. The most important electrode is a common ground electrode, which has to be placed outside the region of dynamic potentials of interest, that is, maybe on the sternum, neck, or cheek. These are surface electrodes, that is, they do not penetrate the skin and hence are placed just over the skin and do not penetrate the surface. Now, these are the most common electrodes that we use for testing, the needle electrodes. They are of various types. The most common one being used is the bipolar concentric electrode, as you can see in the first image. This electrode consists of a hollow steel needle with a steel, silver, or platinum wire running through the needle, which is fully insulated except for the tip. Second is the monopolar concentric electrode, and the third being the single fiber electrode. These are very fine wires capable of recording a muscle fiber action potential of a single muscle unit. These are used frequently because the results are very consistent and reproducible. Now, the hooked wire electrodes. These are fully isolated fine wires which are insulated except at the hook ends and are inserted into the muscle. These are very well tolerated, hence can be placed for a longer time than the needle electrodes. This is the reason why they are used for intraoperative monitoring of recurrent laryngeal nerve during thyroid surgeries. Now, how to do it? First and foremost, we have to explain the procedure to the patient and take a consent. Identify the landmarks, clean the skin, position the patient, infiltrate local anesthesia, and then the muscle-wise specific testing is performed. This is the machine that we use by Natus. The first interface, we have to select the type of EMG recording that we want to do. So we start by a needle EMG, and then on the right you can see we select which muscle we want to test. This is the position. We prefer a supine position with the pillow under the neck to fix the structures and easy identification. The patient lying down is also more comfortable. You can see the procedure being performed. Now, coming to individual muscles. The first important muscle is the main adductor of the vocal folds, that is the thyroarytenoid muscle. The needle is inserted in the midline just below the thyroid border in the cricothyroid notch. Hence, identification of the cricothyroid notch or the cricothyroid membrane is very important to understand and perform LEMG. The needle is angled 30 degrees laterally and 15 degrees superiorly, as you can see. The muscle is encountered 1 to 2 centimeters below the skin. If the patient coughs, that means you have entered the airway and you need to reposition your needle. The position of the needle is validated by a sustained phonation of E. You can see the muscle being tested. The needle is being inserted in the midline, in the cricothyroid notch, and then you go laterally and superiorly to enter the muscle.
Sir, E बोलिए. So don't swallow. E.
On E phonation, you can see a crisp LEMG response. The next muscle to test the superior laryngeal nerve is the cricothyroid muscle. Here we do not penetrate the cricothyroid membrane and stay superficial under the skin. The muscle is 1 centimeter deep. And we check the response by asking the patient to phonate at a high pitch. We are testing the cricothyroid muscle here. We see as soon as we enter the skin, we stay superficial under the skin tangentially to enter the cricothyroid muscle. Another very important muscle is the posterior cricoarytenoid muscle. This is the main abductor of the larynx. It can be tested by two approaches, the midline approach and the lateral approach. In the midline approach, we enter the midline, go through the airway, drill through the posterior lamina of the cricoid cartilage and enter the muscle. Whereas in the lateral approach, we rotate the larynx and just go behind the lamina of the thyroid. The muscle is tested by asking the patient to sniff to abduct the vocal cords. Then is the lateral cricoarytenoid, which is sometimes difficult to differentiate from thyroarytenoid. However, you can differentiate it by asking the patient to phonate for a longer time, and the EMG response, if it decreases, it shows that we are in the lateral cricoarytenoid muscle. Now, what are the common applications and uses of EMG? We can estimate the degree and also prognosticate the paralysis, differentiate it from the mechanical fixation. Also, we can determine the site of the lesion. We can evaluate laryngeal synkinesis after long injuries, intraoperative monitoring, therapeutic injections, for example, Botox injections in spasmodic dysphonia. We can also diagnose various neurological diseases. Now, how to know whether the vocal fold immobility is due to a nerve lesion or it is due to mechanical fixation? So if on EMG we find the potentials and the graph to be normal, then we know it is mechanical fixation. However, if we see these two primary waveforms, for example, positive sharp waves or fibrillation potentials, which we'll see in a while, we know that it is due to a neuromuscular complex injury or involvement, and we can distinguish mechanical fixation. Now, how to know the site of the lesion? If we find neuropathy in both cricothyroid and thyroarytenoid muscles, we can suspect that both the SLN and RLN are involved. Hence, it must be a high vagal lesion. Hence, we do a skull base or CNS imaging. Whereas, if the neuropathy only involves the thyroarytenoid muscle, then it has to be an isolated RLN lesion, and we do the imaging for the neck and the upper chest. Botulinum toxin injection, it is very important if we can do it EMG guided, because it minimizes the dose and it also increases the accuracy of the placement of the needle and the dose and the injection. The diagnostic finding on EMG is a pre-phonatory burst. That means that before the patient starts phonating, we start getting a very crisp EMG waves. Here you can see the injection being performed. This is the needle which we use. Please appreciate the crisp, high-pitched sound that we can see, we can hear, and the waveforms. When we get these waveforms, we inject the toxin. We can also diagnose myasthenia gravis by a decreased amplitude and the number of motor unit potentials with repetitive testing. Now, what is the technique? First of all, we have to understand whether we have entered the muscle or not. This we can understand by insertional activity. This is followed by the muscle specific phonatory tasks. Then the muscle has to be tested first at rest, followed by voluntary contraction. And then we can examine for the synkinesis. To understand the waveforms is very important, and EMG is incomplete if we cannot understand what we are doing and what we are reading. Hence, the waves can be biphasic or triphasic depending on how many times they cross the baseline. In this image, you can see an example of a triphasic wave which crosses the baseline 3 times. The points to remember: we have to take the consent, understand the risk factors that patient have to be counseled for, that is infection and a mild risk of bleeding with transient change in voice. Active skin lesions and acute laryngitis are the contraindications. People on anticoagulants can still be tested unless and until the INR is less than 2. Patients with pacemakers can also be tested. It is not a contraindication. However, it should not be performed with patients who are being given deep brain stimulation and vagal stimulation. The common terms, as we discussed, the first is the insertional activity. These are short bursts of electrical activity lasting for some milliseconds, which are produced when we enter the muscle. This identification is very important. We'll see in the graph. And then the spontaneous activity. A normal muscle will never discharge at rest. Hence, if we have any activity when the muscle is at rest, it shows that there is some neurological problem associated. This usually occurs 10 to 14 days after the denervation due to the Wallerian degeneration. Now, this is insertional activity. We are inserting the needle, and when we are in the right position, we'll see this crispy waveforms for a very short period. This is the insertional activity, and this shows that we have entered the muscle of interest. And how to know whether the muscle and the nerve complex is not normal or its integrity has been injured? We check for the muscle activity at rest. These biphasic or triphasic waves that we get at rest signify the fibrillation potential, whereas this sharp downward deflections, single phase, are called the positive sharp waves. The presence of both indicate denervation or active ongoing denervation of the nerve. Now, what is recruitment? How to know whether the muscle is healthy or the nerve complex is healthy? As the intensity of the muscle contraction increases, there is increased activity and we have more number of motor units. As you can see in the image, the density of the graph that we get of the potentials is much higher as the intensity of the muscle contraction increases. This you can see here. The waveform is so dense that even the baseline appears shifted. This is a sign of a normal muscle nerve complex. After the injury, we have seen the signs of denervation, but how to know whether the nerve is being healed? There is some reinnervation taking place. There is very important sign for the same. These are called polyphasic potentials. They may have 4 to 5 phases, and these are the first signs of nerve healing. To summarize the findings, we see that first, that the nerve is normal and we get a normal waveform. However, on the day of injury, we get electrical silence. After 14 days, when the Wallerian degeneration is complete, we see positive sharp waves and fibrillation potentials at rest. When the nerve is healing normally, at 3 to 6 weeks, we may start getting early polyphasic waves. And early recruitment is a very good sign to prognosticate the patient, and we should not take up the patient for procedures or laryngeal framework surgeries. Coming to a few clinical scenarios. This is a 62-year-old male patient who presented to us with change in voice since 1.5 months. On stroboscopy, we can see that the right vocal cord is involved. And on EMG testing of the left thyroarytenoid muscle, we see the normal waveforms, whereas in the right thyroarytenoid muscle, we are still seeing fibrillation potentials and polyphasic waves. That means that we still need to wait for the surgical procedures to be done. Another very important scenario that we encounter is this. A 33-year-old male patient, a female patient presenting with aphonia for 15 days. She's not able to phonate at all. However, on scopy, we can see normal adduction and abduction taking place. Even the cuff is normal. Yes, you've guessed it right. This is functional aphonia. But how to confirm this objectively? How to tell our patient everything is fine with you? We just need to relax and get some counseling and voice therapy to get your voice back by confirming it with the EMG. The left thyroarytenoid and the right thyroarytenoid, both muscles are normal, and the patient can be counseled accordingly. So in our experience, to conclude, The preservation of normal voluntary activity with brisk recruitment pattern after 2 months implies an excellent prognosis for the patient. However, presence of spontaneous activity even after 4 months are poor indicators. Absence of these voluntary potentials, it has been observed that the return of mobility is very rare if we cannot have them up to 3 to 4 months. In case of any ambiguous result, the study should be repeated after 3 weeks, and a 2-monthly follow-up is ideal to monitor the progress of the patient. Thank you.